special edition of Expressions brought to you by the New Indian Express and Savlon. I have with me Dr. Swapneil Parikh, who's a physician and very active in spreading actual right information, a super spreader of the good kind on COVID. Thank you so much for joining us, Dr. Parikh. I know that you're a physician to Mumbai Indians as well, and the Indian Super League. So I know you juggle a lot of things. So thank you for making time for us. I'd like to get into the conversation straight away and ask you really, where did we go so wrong in our analysis of, how the second wave was going to hit us?
Thank you for having me. It's the $1 million question, or rather the $1 billion question. Where did we go so wrong? The fact is that this was entirely predictable, and it was predicted. So it's not something that happened out of the blue. We know that there were more transmissible variants emerging in December. UKPHE had Public Health England had put out a lot of information about these more transmissible variants. There were some warning signs even by February that there was an uptick in transmission in Maharashtra, and many people, I was just one of those people, but many people, some far more qualified than I am, were raising an alarm about an increase in cases. I was particularly most concerned about the rate of increase in cases and the fact that this increase was occurring in areas where there was already high seroprevalence. That means in areas where people had already been infected in the past. So that was very concerning to me right off the bat. I thought that this indicates higher transmissibility and possibly immune escape. That means a virus that's evading our immune response to it, at least partially. And now we know that both were true. I mean, definitely increase in transmissibility, but also partially immune escape. So what went wrong? How did we get here? Well, when we talk about social distancing or physical distancing rather, to suppress transmission,
Yeah.
you have to look at its impact on future transmission. So our ideal goal is maximally suppress transmission, like New Zealand and Australia, other countries have done, and sustain that suppressed transmission till vaccines are widely rolled out.
Right.
That's very difficult to do. We're seeing even with Australia, they're struggling to manage to do that. Many countries are struggling to manage to do that. When we do what we call an intensive physical distancing strategy, that's like a lockdown.
Yeah.
When does that occur? That occurs either when the health system is entirely unprepared for the levels of transmission that are likely to occur, or when we already find ourselves in the midst of such catastrophic levels of transmission that our health system is crumbling and we have to lock down. So the ideal strategy, like I said, would be to maximally suppress transmission. Difficult to do. Second best would be to have mild, persistent physical distancing, masking, and if transmission went up, would be to lock down, have intensive physical distancing at that time. And then once that crisis was averted, kind of go back to milder physical distancing. The
Right.
worst, and that strategy will still cost a lot of lives. Nothing beats maximal suppression. I'm just giving you the various outcomes. The worst possible thing you can do, I mean, of course, the worst possible is do nothing, but the worst possible thing you can do with a lockdown is do a lockdown and then after a lockdown go to nothing. Because
Right.
then what happens is you've given the population the suffering due to the lockdown. They've taken that. And eventually, because you've gone from intensive physical distancing to intensive physical contact, like mass congregations, your eventual outbreak size is the same. The eventual scale of the epidemic is same,
Right.
just delayed it. So when you do intensive physical distancing like a lockdown, it's expected that transmission will go down, will plummet. When there is what we call, when we look at an epi curve, we see a sharp rise,
Right.
exponential increase. And then we see something called exponential decay once the control measures kick in, which is what we're
Right.
seeing now with our second wave.
Right.
So skyrocketing transmission and then the transmission plummets. You can never think that that means the pandemic is over. It just means the control measures worked. It means
Right.
transmission decreased under conditions of restrictions. What we
Right.
did is we went from that after the first lockdown to intensive physical contact, which is possibly the worst thing you can do because that
Right.
completely obviates all the benefit of the first lockdown. And now we're seeing that our eventual epidemic is probably what it would have been if had we not locked down. It would have kind of the loss of life, the suffering. So you always
Yeah.
have to follow a lockdown with physical distancing that's persistent, and then look at doing a lockdown if things go wrong, and of course vaccinate. So we messed
Yeah.
up multiple points: the strategy of mitigation and containment, the
Right.
vaccine rollout, and then we
Yeah.
were flying blind. So we have so many blind spots in our data today. We can't
Yeah.
accurately tell you how many people have died in India, how many people have been infected, how many people have been reinfected,
Right.
what the age distribution is, what the geographic distribution is, what's happening in rural India. We don't have an early warning system there, and we have very
Right.
poor genomic surveillance. So on
Yeah.
all possible fronts, we have blind spots and we made mistakes. And this
Right.
is these mistakes were made from top to bottom. Multiple people
Right.
made them, from the modelers, policymakers. Everyone made mistakes, and we're seeing what happens.
Yeah. So, Dr. Parikh, have we learned our lesson in this second wave? Again, we've had an intensive lockdown, and again, will we go back again to that same kind of ridiculous behavior, mass congregations? Because we've just had 6 weeks, and some states there have been 6 weeks, some states 8 weeks of this intense lockdown again. Will we start behaving in the same old way? And has the government, meantime, have they made adequate provisions to actually, ensure that vaccines are manufactured at a rate? It cannot be at a rate that you keep pace with the vaccination that is required, but at least stepped it up.
Yeah, I believe that they're trying now. Of course, everyone's trying, but the point is, it's too late. We had to. This is something we had to do in January. So
Hmm.
when we talk about, again, a pandemic peak, you have to roll out the vaccines in time, like the US, UK, other countries have done, for them
Yeah,
to have a maximal impact in the peak. Once the peak is done, I mean, we should still vaccinate to prevent future outbreaks. But once the worst of the peak is done, if we roll out vaccines at scale, then we still have to do it, but we aren't maximally benefiting from it. So of course, all the suffering that's already occurred has occurred. There's nothing we can do about that. But it takes time to scale manufacturing. It takes time to scale distribution. The manufacturers in India, some of them have said that they did not feel there was demand. So they did not
yeah,
feel there was a need to scale vaccine manufacturing. So what they should have started doing in January on a war footing scaling, they didn't have a large enough order to justify increasing their capacity by 3x. If if 500 million doses were procured, then they know that, okay, we have to make this much. But instead it was 10, 20 million doses procured at a time. So there was no clarity to the manufacturers that this is what your expected demand is going to look like. We left them with some uncertainty. Other countries have supported manufacturers to scale out. You know, we can get into discussions about pandemic profiteering after the pandemic. It's
yeah,
important to do, but this is not the time for it. Right now we need to save lives,
right.
and the only focus should have been on scaling vaccine manufacturing, diversifying our vaccine portfolio. So we should have had more than just the two
Possible.
vaccines we have,
Yeah,
three vaccines we have now. And there were manufacturers that applied to India in December of last year. We didn't act on that. So there was a lot of lethargy and inertia and hubris. Thinking that somehow India would have a different outcome from everyone else. And the sad reality is now it is a little too late.
yeah. So, Dr. Parikh, this is also not going to be the last peak. We keep hearing about the third wave, the fourth wave. So there will be, and then there'll be different kinds of viruses as well. Unfortunately, we seem to now be have to learn to live with these viruses. So going forward, what can we possibly do now? Now at least the government realizes that vaccines are important, that they have to use the peacetime, so to speak, to prepare for the big war. At least I hope they've realized it now.
You know, I can't speak to what the government has realized or has not realized, but The fact is that this is what living with coronavirus looks like. So when we
Death
say live with
and
coronavirus,
death.
this is what it looks like. Peaks like this, outbreaks like this. And even in the future, maybe there won't be outbreaks of this scale. Maybe there will be, maybe there won't. But there will be localized outbreaks. So maybe it won't be the whole city of Mumbai getting overwhelmed, but you might see two or three hospitals in Mumbai suddenly get overwhelmed, ER rooms
Right,
struggling, quality of care get compromised there. So the only sensible pandemic exit strategy is universal vaccination. So we just
right.
have to vaccinate at scale with speed, diversify our portfolio, ensure we have the manufacturing to back up the distribution. And we need to do all of that on a war footing. It needs to be our single greatest national priority.
Right.
Everything else is a distraction. Like
Yeah.
fighting the pandemic is our national priority. We
Right.
need to ensure we do that.
Doesn't seem like it, does it?
Again, I am not privy to what goes on in Delhi, so I don't know. But like I said, if we were serious about it, this is something we should have been doing in January and February.
Right.
It's already May. It's already end May.
Dr. Parekh, let's talk a little about the healthcare system. So many of its strengths have been exposed so badly, and it has cost frontline workers, people like you, it has cost them tremendous amounts to take care of the overwhelming number of patients. What are the things that we can do in the interim till we have a system where we have more ICU beds, we have more oxygen per bed? What are the things that we can do? Do we not need to create a new paramedical a sort of cadre, so to speak, which can actually deal with things like operating oxygen cylinders, operate knowing how to work concentrators, basic skills which perhaps we don't really have currently.
Whenever we talk about scaling healthcare capacity, firstly, let me qualify by saying even before the pandemic, healthcare capacity in India was disastrously low. It was a problem waiting to occur, and it was extremely inequitable. So
Right,
the distribution of health resources was very skewed towards urban areas, whereas the needs are very skewed towards rural India. And uh, I'm talking about both in terms of infrastructure, resources, financial resources, and manpower, and human resources rather. So all of those were skewed in an inequitable way. But when the pandemic hit, what we started, it exposed these inequities.
yeah,
The important thing to realize is that even if we scale health capacity, if we have exponential growth, the capacity so scaled will be breached. So we have to do both things. We have to flatten the curve of hospitalizations and hopefully infections too. And we have to scale. So we have to reduce the load on the health system and simultaneously increase the capacity of the health system to respond. We have to
right,
do both. The critical step is reducing the load. If we don't
right,
stop exponential growth or prevent exponential growth next time, then what's going to happen is whatever capacity we build, we can't keep up with exponential growth.
right.
And we're seeing this happen across the world. And we saw it happen in Italy, it's happening in Japan right now, it happened in the US, it happened in the UK. So this is not an Indian problem, this is a mathematical problem. We
Right,
cannot outcompete the mathematics of exponential growth.
right,
But where do we build the health capacity? Where is the need? We don't know. Like there are such data blind spots right now that even in, let's step back from building capacity.
right.
Let's say the issues in Delhi started improving, we deployed a lot of resources there, and now suddenly we see things are getting disastrous in UP.
Yeah,
Then what we should do in real time is say, okay, we should move healthcare workers, oxygen,
from Delhi to,
transportable capacity from Delhi to UP. Or if
yeah,
things are getting better in Maharashtra, from Maharashtra to there. But of course, that's not going to happen. There are political reasons it's not going to happen. And even if everything else was figured out, we don't have the data to know what's heating up in time to make those preparations. So we need to fix that. We need to remove the blind spots. We need to have real time credible data. And when we have real time credible data, we have to want to act on it so it actually affects health outcomes, it improves
right,
health outcomes. And then, yes, we need to build capacity across the board. So, like you mentioned, from paramedical workers, auxiliary health workers, we need to start from there. We should build upon the ASHA worker program, enhance their skill sets, give them more responsibilities, improve their remuneration, increase the
Yes.
number of ASHA workers. Then we need to start scaling out primary care in India and all the sub centers under the primary care centers. So we need to start doing that. And of course, we need to build more ICUs, more high dependency units. We need to have surge capacity. The biggest thing here, though, is that even the even the lack of capacity isn't distributed equally in society. So
Yeah.
this time, yes, even the affluent and privileged felt it,
Hmm.
but not like the less fortunate felt it.
Yeah.
I mean, there's a at least we have the voice to say we need help on Twitter
Exactly.
or WhatsApp. There
Yeah.
are people who don't even have the voice to ask for help. They just
Yeah.
die. They're
Yeah.
not remembered. No one notices their deaths. We don't record their deaths.
Right.
So even when we start scaling health capacity, we need to figure out how do we ensure equity in this system, because ultimately if we have one part of the country that is doing well and another part of the country that has outbreaks, people are mixing. It's
Yeah.
going to impact the whole country. We need to scale healthcare very sensibly in India, and we need to ensure that we put health in the center of all our discussions of what citizens need. Because can you really be a great nation if you're not a healthy nation? And
Absolutely.
can you be a happy nation if you're not a healthy nation? And ultimately, don't we want people here to be happy, to be
Right.
able to feel like they can thrive, have the opportunity to maximize their potential? All of that starts with health and education.
Absolutely. And those are our two biggest failings,
Absolutely.
and have been our two biggest failings.
Continue to be.
Yeah. So now, if I were to ask you, what are the top five things that any health minister, any reasonable health minister, especially one who's a doctor, you would imagine is, perfectly qualified to do this. But if I were to ask you, what are the five things that, the health ministry of this nation needs to do right away? How would you list that list of priorities?
The first priority is vaccination. That's the absolute top priority. So I'd say that equally manufacture, uh, import, and distribute. We need to scale all three of those.
Right.
That's key. That's the most important layer.
But just to develop on that thought, currently we have this crazy idea of state governments bidding for these vaccines, and you know, I think except for the BMC, it hasn't worked anywhere else. Does that work? The decentralization of acquisition?
Of course, it doesn't work. Like we're seeing that it's not working.
Yeah.
Essentially, passing your onus, your responsibility uh, onto other people. And I can understand that there may be some need to share the financial burden between the center and the state. So come to some kind of agreement with the states and say that okay, we'll procure centrally, and you can contribute X amount
Right.
in relationship to what you need. But we have to remember that we need to vaccinate urgently right now.
Yeah.
This is not something we have time to figure out over the next few weeks.
Right.
We need to procure the vaccines, we need to scale that ASAP and figure out the rest of it later. We can't keep putting roadblocks in the way.
Mm.
The second is testing.
Yeah.
So, like vaccines will prevent infections. Testing will also prevent infections. So, it allows us to identify individuals who are infected and infectious and isolate them and
Yeah.
prevents the secondary transmission of infection.
Yeah.
We need mass testing. Testing should continue even as we start rolling out the vaccines. In some settings, we need to continue testing. In vulnerable areas, we need to continue testing even after, and we need to continue surveillance-based testing. So we need that. And with with that, I will lead on to data. So one is, of course, as relates to testing the spread of infection, but real-time credible data
Right.
in the form of, sorry, also in testing I will include genomic testing.
Okay.
So along with testing for infection, we should also be testing for the variants, so
Right.
genomic surveillance, and that includes testing with PCR, with RT-LAMP, CRISPR, includes testing with rapid antigen tests, spectroscopy based assays, genomic sequencing, wastewater epidemiology. We should start testing the sewage for
Yeah.
the viral RNA and for variants. That's critical. A recent outbreak in Australia was detected in the wastewater, and
Oh,
numerous studies have shown that if you test the wastewater, you can detect it almost a week before you can detect it by community based testing, or until you wait for people to come to the hospitals.
right.
So, and then real time data. So we need testing data, data on the variants. Genomic epidemiology is so important. We need data on breakthrough infections, reinfections. All this data needs to be credible. We don't can't have blind spots in rural India. We need data about hospitalizations. Who's getting hospitalized, the age of the the age of the people getting hospitalized, what percentage of vaccinated individuals are getting hospitalized. There's so many different data points that we need that we just don't have right now.
Right.
So critical that we have those, and we have those in real time. The fourth is not much that we can do about it right now. Maybe we can look at redistributing healthcare workers from areas where health workers and health resources, areas where there is limited or slightly less spread, uh,
Right.
into areas where there's more spread. But that's something more for the long term. We need more healthcare workers. We need more health capacity. And then finally,
Doctor, sorry to interrupt again. But Dr. Parikh, Dr. Devi Shetty had suggested this, which I think Kiran Majumdar Shaw had also echoed, that why can't we have this mobile health force, which you were also sort of talking about a little earlier, which goes from district to district, moving along with the with COVID with the COVID infection. Is that not still possible?
so, I mean, more than having a mobile health force, what I'm suggesting is a little simpler. Is that if you start seeing control occur in Maharashtra,
Yeah.
but you start seeing a bad outbreak in Kerala, or vice versa, then
Right.
states should be able to say, okay, we're sending you health resources
Yeah.
now.
Yeah.
Of course, because it's the right thing to do, but also because it's enlightened self-interest. A
Yeah.
bad outbreak in Kerala can come to Maharashtra, a bad outbreak in Maharashtra can go to
Right.
Kerala. So more than having mobile units, we just need to have a real-time system where we can redistribute health resources based on where the need is.
Right.
And we
And
can
that
do
is
that.
possible even now.
It is, it
You
is.
don't have to wait for scaling up.
Yeah, scientifically, yes, it's possible. In the terms of the politics of it, I'm not sure. I don't have
Yeah.
a perspective there. And finally, what we need to do is other tools, other layers to reduce transmission. So that's high quality masks. So FFP2 or N95 respirators. We could start handing these out. They're pretty cheap to make. You can
Right.
use them, for a fair bit. You can hand out a few to each person so that they can rotate. Paying attention to ventilation, uh, air filtration, indoor air quality monitoring. This is going to be key in hospitals, offices, industries. Pay attention to the air quality. This is a pathogen that spreads via the air.
Right.
That's where we need to focus. People need to maintain distance, and policymakers need to keep policies in place that don't allow mass congregations.
Yeah.
So once we're through this period of high risk, even as we start scaling the vaccines, until we vaccinate enough people, we'll need mild, persistent physical distancing. And then everyone else has to contribute. Everyone else has to play their part in breaking the chain. Stay home if you're sick, get medical care. All the
Right.
things, do it all. Everything that the formula has not changed much since the
Right.
beginning of the pandemic. We've added vaccines, and
Yeah.
more people acknowledge aerosol transmission, airborne transmission now. But the tools are pretty much the same, save for vaccines. So we just need to do all of that.
And yet, when you say it, it sounds so simple. Yet, we're in a situation where such simple things have not been communicated adequately. Do you think the media has also played a part in not in not owning up to its responsibility?
Um, I don't know. I'm not sure. I don't consume too much media content. I tend to look more at studies. I'm not sure I'm the best person to comment on that. I don't want to give an uninformed opinion. But maybe what we can start doing is putting out simpler messages. So
Yeah.
mass testing and wastewater testing. I think mass testing the government has kind of picked up on. They picked up on antigen tests but they've not picked up on spectroscopy based tests. That's so
Right.
important. It's even faster than antigen tests
Right.
at scale, cheaper, faster, no reagents. So that's something that they need to be aware about, that these tools exist. Wastewater testing. This is something we've had in India for so long. It helped us with polio.
Yeah.
We actually have all the infrastructure to do this. In some places it's being done, but not at this scale, and it's not being done for variants. We can actually start sequencing sewage to know what variants are spreading before we find out in the community. That I think is a critical tool. You see, testing can miss, clinical data can miss spread. But if you're testing the entire catchment area, if you're testing the
Yeah.
sewage, you'll notice something's going wrong. So I think that
Right.
is one very simple message that maybe for some reason hasn't been amplified enough, that we should start amplifying a lot more. Uh, Air quality. Air quality is another one. And this is not necessarily something for the government. Maybe they can set standards for hospitals and
Yeah.
workplaces. But educational institutes, hospitals, workplaces should be aware that they don't need to spend a whole lot of money to update
Yeah.
their entire HVAC. They can put in high quality HEPA based air cleaners. They can put in low cost CO2 sensors into workplaces to understand what their fresh air is like. Uh, do they have adequate air cleaners to reduce the risk of infection? These are some things, simple messages that we can start putting out in the community that can help.
And Dr. Parikh, the more you say all this, these are also actually business opportunities. So it's actually in the self interest of a lot of people to not just observe these protocols, but also in a way to create, the technology to help these protocols be observed.
Absolutely. So a lot of these technologies exist.
Exactly.
We don't need to do a whole lot of innovation. We're not trying to reinvent the wheel. Everything we discussed right now
Yeah. It's
exists.
available.
It's available today.
Right.
And it's been available for a long time. So the question is just rolling it out, creating awareness, making
Right.
sure. For example, I have had, I mean, of course, I from a privileged position, not everyone can afford this, but I've had HEPA air cleaners in my house for several years now, just
Right.
because it's so important for your health. So these tools have been available, and I think the pandemic has highlighted that they're even more important.
Is there one thing, possibly one thing that you have noticed in this time of adversity, which has allowed you to feel somewhat happy rather than just be dejected at the state we're in? Is
Yeah,
there one bright spot possibly?
personally, as a human being, I try to stay happy all the time. Like, I believe happiness is more about my mental state of mind, what's happening inside me. Of course, things happening around you do impact that, and you do feel sad. I think it's important to be able to stay happy as a doctor, even in hard times, because if you don't, it's just gonna sap your energy.
Yeah.
So I probably can't highlight any one thing, but any one thing that has per se made me happy. But I do hope that our health system will be more equitable, that more people will have access to healthcare, that we will pay more attention to our health in the future, and that we'll start decentralizing healthcare to go from large tertiary care hospitals to actually healthcare moving into the home. We've recently rolled out self testing at home for COVID 19. Just imagine the potential for that. You order a package and you get a bunch of tests for a
Right.
number of disease outcomes, not just infectious
Yeah.
diseases. So I think a lot of disruption in the health
Yeah.
industry for positive reasons. Maybe that's one in the post-pandemic period. Right now, the disruption is very painful, but in the post-pandemic period,
Yeah.
maybe that disruption is something we really needed.
Dr. Parikh, I have to ask you because I know you're not a soothsayer, but when do you see us getting back to some kind of normality?
So what I will categorically say and reassure everyone that we are going to get back to normal. A lot of people say COVID 19 is our new normal, things will
Yeah.
never go back to normal. Those people don't like parties, they are no fun. And do not invite them to any of the post pandemic parties, of which there will be many. So we will go back to normal. Everything will get back to normal. Um, everyone
Spectator
alive,
sports will be back, theaters will be back, people
absolutely.
will be
Indoor dining will be back,
yeah,
parties will be back, music will be back. All of that. Art galleries will be open again, bookstores will be open again. Everyone alive today is here because our ancestors survived pandemics.
right.
We know this. There's no disputing this fact. And yes, we'll survive. Yes, things will get back to normal. The people who survive will be happy that things are back to normal. But it's a fight that cost us a lot of suffering. Millions died needlessly, preventable deaths. And there was a lot of suffering that we had to take on to get back to normal. So I think we need to acknowledge that. But I think things will get back to normal. As to when, it's very difficult to say because it's not just about the virus or how many people are infected. It's also about how policymakers respond, how individuals respond, how quickly we can vaccinate. So I would feel once we have about 70 to 80%, or maybe a little higher, 70 to 90% of eligible adults currently vaccinated, we'll start to see things going back very much to normal. I also think that's very important to start doing the science necessary to prepare for having to vaccinate below 18 because 40% of our population is below 18.
Right.
If we want to get to the herd immunity threshold required for containment,
Yeah,
then we have to realistically look at vaccinating below 18. And it's our duty to protect them as well. Everyone deserves to be protected.
absolutely.
So this when really it's really difficult to say because there are so many assumptions that we make, and a lot of those assumptions are if we do everything right. So if we continue the way we are continuing now, it's going to be a long time. It's going to be a year. If we do everything right, maybe longer than a year. If we do everything right the way we're supposed to, it could be sooner than that. A lot of it just comes down to how quickly and how well we respond.
Right. Dr. Parikh, you've also written a book, I think, during this time, the coronavirus book. You want to talk a little about writing that?
Right. Thank you for giving me the opportunity to talk about my book. So this is the book. Um, I I wrote it. My co-authors, my dad, Dr. Rajesh Parikh, and one of my colleagues, Mahera Desai. The three of us wrote it together. In January, we started talking about, based on information coming out of China, that this virus was going to, January 2020,
Right.
that this virus is going to go pandemic. By February, we started writing the book for Penguin Random House. And I think by end February of 2020, we turned in the first draft to the publishers. And I think by about April, it was available as an ebook. But because of the lockdown, it took some time to be available in what I actually think is quite a nice looking paperback.
Yeah. Yeah.
So for the paperback, it took some time. I think it was out in June. I want to say maybe in June it was out. And I think a lot of the things that we wrote uh, have the projections we made in the book have come true, have played out how we said they would play out. Um, a lot of a lot of the information we put in there is still very relevant today, and we tried to convey scientific information in a way that's consumable and accessible for people who don't necessarily come from a scientific background. So it's written in a way that's enjoyable to read, I hope. Not, well, I'll rephrase, not entirely rubbish to read. That much I can promise. And it was a lot of fun writing it. On a side note, all the royalties I make from the book go to
Yeah, I
various
believe.
pandemic relief efforts. So it's for a good cause. I'd recommend. I'm biased, but I'd recommend everyone picks up a copy on Amazon, Flipkart, other places where books are sold, and has a
Yeah.
read.
Thank you so much, Dr. Parikh, for joining us. I know you're very busy, but it was really a pleasure to talk to you.
जब जब हम धोएंगे हैंड वॉश या साबुन से हाथ, लड़ेंगे हम जंग कोरोना वायरस के खिलाफ। सैवलॉन